Hello, everyone. Thank you for joining us at this 21st session of ISSUP Nigeria chapter webinar. My name is Martin Agoje, and today we have one of our very experienced colleagues in the field of addiction science in Nigeria, in the person of Dr. Kingsley Okonoda, who will be leading the discussion for the day. And he will be speaking on recovery-oriented services in co-occurring disorders. And to moderate this session with me is Ejikeme McBishop Ogoje. Ejikeme is the head of the editorial and webinar team of ISSUP Nigeria chapter. But before I call on Ejikeme, let me quickly remind attendees that while the presentation is going on, please remember to use the chat box to ask your questions. So Ejikeme, please introduce our speaker for the day. Thank you.
Okay, thank you so much, Dr. Martins. I want to welcome everyone to the 21st session of ISSUP Nigeria Knowledge Update. And today we have our presenter, Dr. Kingsley Okonoda. Dr. Kingsley is a consultant psychiatrist and the immediate past deputy chairman of the Medical and Social and Rehabilitation Psychiatry at the University of Jos. He earned his Bachelor of Medicine and Bachelor of Surgery degree from Obafemi University, as well as a Master in Public Health from the University of Jos. He is a Fellow of the West African College of Physicians, Fellow of the Institute of Corporate Administration of Nigeria, and Fellow of the Institute of Management Consultants of Nigeria. Additionally, he is a certified manager.
Sorry, I think we had some network issues from Ejikeme's end. I think he's done with the introduction. Please go ahead with the presentation.
Over to you, Dr. Okonoda. ISSUP Nigeria chapter. Dr.
Thank you very much. Thank you very much, Ejikeme, for that introduction. Thank you, Martins, for granting me the audience, granting me the opportunity to discuss with people today. Unfortunately, we are not having good connection from Ejikeme's side, but I think we can just go ahead. So I'll be talking on recovery-oriented services in co-occurring disorders. And like I've been introduced, I am a reader in the Department of Psychiatry in the area of addiction, social and rehabilitation, psychiatry. So this it seems to you, and let's see how the discussion goes. All right, so in the next few minutes, we want to go through these learning outcomes. We want everybody to be able to understand that co-occurring substance use and mental illnesses are common among people in treatment. And we want people to understand that people with co-occurring disorders are more likely to relapse and have worse psychosocial outcomes. We want people to understand what integrated care for co-occurring disorders entails, and then to understand and articulate the positive outcome associated with integrated care for people with co-occurring disorders, to understand the fundamentals and components of recovery for people with co-occurring disorders, and then to understand the roles of providers and services in recovery for people with co-occurring disorders. Now, by way of introduction, people with substance use disorders are at higher risk of having a mental illness than the general population and vice versa. That means that even people with mental illnesses are also at higher risk of having substance use disorders. And the existence of substance use disorders and mental illnesses is termed co-occurring disorders. And co-occurring disorders are very common among people in treatment. As a matter of fact, some experts have said that having co-occurring disorders, or in general comorbidity amongst people in treatment, is the norm and not the exception. So while people with substance use disorders may have coexisting physical health conditions like hypertension, diabetes, and so on and so forth, and may qualify as co-occurring, the term co-occurring disorders here is used to refer to coexisting substance use disorders and mental illness. What I'm saying in essence is that at every point when I mention co-occurring disorders, I'm specifying, narrowing it down to people with substance use disorders and mental illnesses, and not people with substance use disorders and physical illnesses. Now, like I said, comorbidity is important because it is the rule rather than the exception with mental health disorders. Almost everybody with a mental health disorder will have a comorbid illness. And in this case, when people now have comorbid substance use disorders, we call them co-occurring disorders. Now, why is this important? It is important because research has shown that up to 56% of people with the most serious mental illnesses have a co-occurring substance use disorder within their lifetime. And it is the norm rather than the exception for people to have co-occurring disorders. And the lack of recognition of the high prevalence of co-occurring disorders may leave many consumers undiagnosed and untreated. Like I was saying, studies have also showed that compared to patients without co-occurring disorders, patients with co-occurring disorders are more likely going to relapse, are more likely going to be hospitalized, are more likely going to be violent, incarcerated, homeless, are more likely going to be infected with HIV, AIDS, hepatitis, and other diseases. So what we are saying is that the morbidity around people with co-occurring disorders is more than people with single disorders. And studies have also showed that receiving care in systems in which mental health and substance abuse treatment were separated often leads to exclusion from services in one system, and patients are told to return where other problems were under control. So what this means is that people move from one program to the other, and many times they are not able to get the best of care. So such patients also have difficulty making sense of the different and disparate messages about treatment and recovery, because people are talking to them about substance use disorders in one treatment facility, then they move to another treatment facility, they are talking to them about mental health disorders. But experience have also shown, studies have shown that patients with co-occurring disorders who are being treated in non-integrated systems of care have poor outcomes because they have to move from one area to the other, and so on and so forth. And so they sometimes get confused even with the different messages that are being passed across. And that is why the integrated treatment for co-occurring disorders is what is being advocated for in the best of centers all over the world. And what do we mean by integrated treatment program for co-occurring disorders? Integrated treatment program integrates treatment plans and involves the treatment of both serious mental illnesses and substance use disorders, so that consumers do not get lost, excluded, or confused going back and forth between different mental health and substance abuse programs. As a matter of fact, a lot of people will tell you that they get, will I say, stigmatized moving from one program to the other. So in the integrated treatment program, both mental health facilities and substance treatment are existing together. So patients receive one consistent integrated message about substance use and mental health treatment. Secondly, the clinical treatment is integrated. So even the clinicians are people who are knowledgeable about mental health or mental illnesses as well as substance use disorders. So integrated treatment specialists is what they are called. They have the knowledge of both the substance use disorders and serious mental illnesses and understand the complexities of the interaction within the two disorders. So the goal of this evidence-based practice is to support patients in their recovery process, because that essentially is what everybody is looking to achieve, recovery. Now, what are the basic principles of recovery, or basic principles of the integrated treatment practice? Number one, the mental health and substance abuse treatment are integrated to meet the needs of people with co-occurring disorders. Number two, integrated treatment specialists are trained to treat both substance use disorders and serious mental illnesses. Number three, co-occurring disorders are treated in a stage-wide fashion with different services provided at different stages. For example, many times, people with co-occurring mental illnesses and substance use disorders, we want to first of all treat the mental illness, get the person to be able to come back and be in touch with reality. And then, of course, before the person can also follow therapy that is involved in substance use disorder treatment. So, the motivational interventions are used to treat consumers in all stages, but especially during the persuasion stage. And substance abuse counseling using a cognitive behavioral approach is used to treat consumers in the active treatment and relapse prevention stages. Multiple formats for services are available. So people can go through individual therapy, group therapy, self-help, and even family therapy, even as things like couples therapy, and so on and so forth. And medication services are integrated and coordinated with psychosocial services. So everything is going together pari passu. So in contrast with non-integrated treatment, integrated treatment is associated with the following positive outcomes. One, there's reduced substance use. Most people that have gone through integrated treatment, the outcome is such that they reduce their substance use, and in some cases, people actually get to the point of abstinence. Improvement in psychiatric symptoms and functioning is also noticed. There's decreased hospitalization, there's increased housing stability, fear arrest, so people don't get involved in things like crime and so on and so forth. And the quality of life is also improved. Now, in order for us to have an holistic understanding of what we are talking about, because a lot of people actually think that the issue of substance use disorder is outside the purview of mental health or mental illnesses and all that. But let's look at this definition by WHO once again. It will conceptualize our discussion. It says mental health is a state of well-being in which the individual is able to realize his or her potential, cope with normal stresses of life, work productively, and be able to contribute to his or our society. I will just say that essentially that's what everybody came to this world to do, to be able to do these four basic things. And the concept of psychiatric rehabilitation also helps us to conceptualize our discussion better. Psychiatric rehabilitation is those practices that seek to promote recovery, full community integration, improve quality of life for persons who have been diagnosed with any mental health condition that seriously impair their ability to lead meaningful lives. So when people get out of rehab and they say, oh, okay, it's not taking substances anymore, I always ask, is he productive? Is he performing in the roles that he deserves for himself? The role of a husband, the role of a father, and so on and so forth. All right. So psychiatric rehabilitation also are those services that are collaborative in nature, person-directed and individualized. These services are an essential element of the healthcare and human services spectrum and should be evidence-based. Well, I dare say that that is the case in Nigeria these days, in the best of centers. Now, in psychiatric rehabilitation, we focus on helping individuals develop skills and access resources needed to increase their capacity to be successful and satisfying in the living, working, learning, and social environment of their choice. This is what the Psychiatric Rehabilitation Association of the United States, this is the definition. Now, if you remember, if you can recall what I talked about, psychiatric rehabilitation, it talks about helping recovery. So what then is recovery? A lot of people, when we talk about recovery, they think that we are talking in terms of cure. But you and I know that most chronic illnesses, we don't talk about cure, but we talk about managing. But in this case, we now talk about recovery. So what does recovery mean? The working definition by SAMHSA as far back as 2011 says, recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. You can easily relate it back to the definition of mental health, that is talking about the individual being able to actualize his or her potentials, and so on and so forth. And Patricia Digan, who is one of the proponents of recovery, she herself being somebody with lived experience, said, define recovery as rediscovering meaning and purpose after a series of catastrophic events, which mental illnesses. She also goes on to say that it's a process, a way of life right now, an attitude, and a way of approaching the day's challenges. As a matter of fact, the story of Patricia Digan is one that can inspire anybody. She was diagnosed with schizophrenia, and while in treatment, she saw that the way in which physicians were treating her and all that, they were labeling her schizophrenic and so on and so forth. It was not something that engendered recovery. And she decided that she was going to change the face of psychiatric practice. And she went into this psychiatric rehabilitation and recovery, and her life seems to have better meaning even after treatment. And that's what we're advocating for people with co-occurring disorders. All right. So recovery is deeply personal, and the process is unique to each individual. It talks about the person's attitude, their values, their feelings, their goals, their skills, and the different roles that they have, they desire for themselves. It is a way of living a satisfying, hopeful, and contributing life with the limitations caused by the illness. I always tell some of my patients, I say that you have mental illness or you have substance use disorder, it's not a condemnation to a substandard life. So recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. Now, when we talk about recovery, what do we mean? What are we talking about? We are talking in terms of recovering from the stigma that may be incorporated in the very being of the person who has substance use disorder or mental illness or co-occurring disorders. Because many people, it is the self-stigma that is even worse than the stigma that other people give onto them. It is recovery from the iatrogenic effect of treatment settings, where people are labeled, where people are, they are called condition rather than understanding, and rather than understanding that these people have areas of strength and all that people need to explore. And then is recovery from the lack of recent opportunities for self-determination, recovery from the negative effect of unemployment and crushed dreams. Because a lot of people, once they are diagnosed, it seems as if they are limited. So recovery is a complex, time-consuming process. It's not a linear process. People go forth and back in recovery. Sometimes you have to chart new course and so on and so forth. Recovery is not a straightforward process. It's unique to each individual. What are the fundamental recovery concepts that we need to keep in mind? Number one is that recovery is not the recovery from the disease. So it's not as if you have been treated, you have now recovered from the mental illness, you are recovered from the substance use disorder, that those things have been cured. No. Recovery is the recovery of the person, the mentality of the person, the orientation of the person, the attitude of the person, the opportunities the person now seeks to explore, and so on and so forth. It is person-centered. It's not illness-centered. So it's not the same thing as cure. And at every point in time, no matter how bad the situation is, we offer hope, and recovery is goal-directed. It looks more in terms of the strength and resilience that the person can have. It's not focusing on the weaknesses, on the threats, but rather in building resilience. So recovery for each individual is unique. You cannot say recovery for individual A has to go through the same process for individual B. No, it is built on the individual's choices and goals. So we are not practicing a paternalistic approach here, where you say this is what you must do. And I see that a lot, where parents will come and say, I told him to do this, I registered him here, I did this day there. No, recovery in this case now is looking at that individual and saying, these are the options, these are your strengths. What would you rather do? What are your goals? What are your aspirations? So, but one of the important things that we should also note here, despite all, is that recovery can occur without professional intervention. There have been individuals by themselves who actually took the bull by the horn and changed their lives. However, it seems to be easier, more profiting, faster, and so on and so forth when we explore professional help and services, especially from the experts. So recovery is facilitated by the presence of people, which we include professionals who believe in and support the person in recovery. So at every point in time, sometimes even when the individual does not believe in himself, we believe in him. That is the concept of recovery. So what are the roles of services and service providers in recovery, especially for people with co-occurring disorder? All focus on recovery is on vision and goal. So there must be recovery, vision, and goal. All of us must focus on recovery, vision, and goal of that individual. Many times, people may not be able to conceptualize their goal. And that's one of the things that we do as service providers, to be able to help them to discover themselves, discovery of who they are meant to be and what they are meant to contribute to this world, despite their illnesses. And recovery, the role of service and providers is to also to believe in the person, no matter what. And services promote the recovery journey, that is reclaiming a meaningful life, by doing the following: basing services on a set of values. So even your vision statement, your mission statement, your values should incorporate recovery-oriented beliefs and so on and so forth. Even in your record keeping, in your daily practices, everything should exude that hope and belief in the clients that you are dealing with. And you also exhibit that through a set of competencies within a partnership that alter the way in which any intervention is delivered. So you are thinking in terms of partnering with the individual, because people are the best experts of themselves. No matter how the expertise you have, they are the best expert on themselves. So you partner with them, it's partnership. You help them and bring out the best that they could be. And of course, these are some of the things that we do in recovery-oriented services. You can see now the person's recovery vision is in the middle. So we help in treatment, rehab, supported employment, supported education, case management, and then of course, general wellness. And then of course, there's peer support, rights protection, and crisis intervention. These are some of the things, some of the areas in which recovery-oriented services are rendered. And some essential client services in recovery and in caring system will include the following. These are essentially definition of terms for us to know what they include. So, for example, when you talk about the treatment, you are talking in terms of alleviation of symptoms and distress. So when the symptoms are relieved, then you know that the person has achieved this. Then there's crisis intervention, controlling and resolving critical and dangerous problems that the person may have so that the person's personal safety is assured. Well, case management is one area in which we need to look into more holistically in this country, in our services. And this involves obtaining the services that the clients services and so on and so forth. It doesn't mean that all these services have to be in one area because it's practically impossible. But it means that we have a case manager who is a central coordinating person who is able to take, to help the patient get those services needed. I hope we are all still together.
Yes, doctor, we are. Please go ahead. We can hear you. Yes, we can hear you loud and clear. Yeah, thank you.
Exactly. And then rehabilitation, which is one of the things that we always talk about, is involved developing the client skills and support related to client's goal. This is what we usually talk about. But I always say that rehabilitation is from the beginning. Rehabilitation has started, and rehabilitation is a continuous process. Now, it is about the individual being able to get back to society and function in the roles that he desires for himself. And sometimes people even go and get better roles, better visions, better skills because they are going to rehabilitation. It's not just about people stopping substance use or being alleviated from their symptoms. And then enrichment involves engaging clients in fulfilling and satisfying activities, even while in treatment or even in the continuous phase of rehabilitation. So people get developed. There are people who have been able to get admission into the university. There are people who have been able to get some other skills and so on and so forth. Right protection talks about advocating to uphold one's rights. We need to also be protecting the rights of our clients. Basic support means providing the people, places, and things the clients need to survive. Things like shelter, meals, and so on and so forth. And self-help, exercising a voice and a choice in one's life. People will say there should be nothing about us without us. People should be involved and should be able to help themselves. We must support self-efficacy at all times. All right, so we can say that when we talk about recovery, we should know that we are not treating diagnosis. I, as a physician, I dare to say that I have to I have to unlearn that medical model of always looking at things in terms of the diagnosis only. But here we are treating and managing the person, not the diagnosis. Because two people can have co-occurring schizophrenia and substance use disorder, for example, and the approach to managing them will be different based on individuals' circumstances and so on and so forth. And then it has to be about choice, not coercion. It's partnership, not compliance. We're not just expecting people to follow us sheepishly. Sometimes they are the ones that will give us the direction to say, this is where I want to go. And then we partner with them to get there. It's about hope and not hopelessness. So these are very important recovery values that any provider should be able, the spirit with which we carry out our treatment modalities. And what are the program components? Now, when we're setting all our programs, or when we're developing our programs, and so on and so forth, what are the things that should reflect that recovery-oriented service that we're talking about? Number one, our mission, our policies. Everything must revolve around the client. I say patient because I'm a doctor, but missions, your mission of your organization, your policies, everything you do is in the interest of the client. Even the procedures and activities that are carried out, the record keeping is such that is to elevate. Elevate these people, not to put them down. even the physical setting, the network of settings, the services. It's not such that you are saying, oh, this is a staff toilet, clients cannot use this, and so on and so forth. You do it in such a way that it shows dignity to everybody. So what then changes in this our recovery-oriented services that we are talking about in the management of co-occurring people? Number one, we are changing from provider-centered services to recovery-centered services. What that means is that we are not exercising undue power over people, but we are helping to awaken people's power, the power they have in themselves to be able to alleviate their problems, to be able to solve their problems. Self-efficacy, let me put it out. And of course, we are moving from, making them know that they have choices. They have many of choices. They must not necessarily do just what we prescribe for them or we want them to. And then, of course, we are moving from that issue of risk and fear and dreams. So people will always say, will I be able to do this and not those? And I will tell them, leave that. Craft for yourself a new life where many times I talk about the 24-hour daily schedule, and everything you do is geared towards building your dreams, your hope, meeting new people, and so on and so forth. And then the provider adapts now to the individual, not the other way around. And of course, there's increased abilities and meaningful life. I've given you the story of Patricia Digna, who now became an expert in recovery. Now, what are the examples of program components that reflect recovery-oriented services we are talking about? That is this focusing on the person now rather than the service. For example, our physical setting. I've mentioned it before. So the program treats individuals as all beings because we now don't have segregated bathroom, segregated toilets, and so on and so forth. Everybody, for example, people can be in the same common room, recreational area, and so on and so forth. So you see that there is dignity. In fact, some people will say, oh, even the staff, even the psychiatric nurses and all those things, they don't have to wear uniform so that everybody will feel the same. And then, so what are the activities that reflect that? The clients who can and want to teach program classes are encouraged and supported in doing so. I've had clients that have taught others in areas in which they are good at. I've had physicians come and teach about medical issues. I've had people who can do programming and so on and so forth. So the sign-up sheets that entitled things I know well and want to teach others. So people can sign and then they can make it available. And then what do? We put it as part of the program so that even as they are going through their treatment, they are also helping others to build capacity in other areas. That is one of the things. Then even the program network of settings and options, such that people with a range of aspirations are easily served. So it's not, for example, somebody asked me one time, he said, oh, you have skill acquisition? And I said, if I just come and build a particular skill here, what about people who are PhD holders that have had to treat? So we can do it in such a way that everybody is welcome and you can always have link to the services they need and they require. So program activities reflect goals at all levels. Going to the university, having a family, opening a business. For example, people will talk about entrepreneurship training and so on and so forth, financial independence, financial literacy, living with a roommate, doing part-time job, and so on and so forth. So all these things are things that reflect recovery-oriented services. And of course, the procedures, the way we do things, says nothing about us without us. So people with lived experience participate in decision-making for the service. As a matter of fact, in many places, you have people have morning meetings where decisions are made in collaboration with the staff. And some of the services and things that have been introduced into the service have been suggestions from clients who are in treatment and based on their own experience. That they are clients does not mean that they are not experts in other areas that we may have little or no knowledge in. And then, of course, the staff training also focus more on possibilities and future options, not only on relapse prevention, compliance, risk assessment. These are things we always do, but we now focus more on positive things. So, what then is the focus of care? So the provider, I'll be running up in the next few minutes, the provider becomes more of a coach than the person who is in charge of the action. You know what coaches do? They don't play, but you know, they are the ones that help people to be able to get the best out of themselves. Of course, permit me to mention that Jurgen Klopp is such a coach that has been able to get the best out of many Liverpool players. Outcomes are also identified in terms of the person's own vision and a meaningful life. So, in conclusion, all services and programs in recovery-oriented services, especially for co-occurring disorders now, are centered around the person's long-term recovery vision. And all natural supports are centered around the person's long-term recovery vision. So even our physical environment and so on and so forth will be supportive for their recovery vision. And people with ill experiences have a say. They help in the design, implementation, delivery, and evaluation of services. And services will include basic recovery values throughout the infrastructure, right from the mission statement, the policies, the procedures, record keeping activities, physical settings, and so on and so forth. So thank you very much for listening to me. These are some of my sojourn in the recovery world, and these are my references. I'll be very willing to entertain your questions and contributions. Thank you very much.
Thank you so much, Dr. Okonoda, for that brilliant presentation. I want to believe the attendees have benefited from your words of knowledge. Before we proceed, let me quickly apologize for the network issue we had at the beginning of the session while introducing the speaker. Please feel free to visit ISSUP website or the link you use in registering for this session. You can also see more of Dr. Okonoda's bio. At the moment, we don't have much questions, except that attendees are very happy with your presentation. They have expressed appreciation for your words of knowledge and with a positive comment. While we wait for maybe other questions or questions to come in, let me quickly highlight some of the points made by our speaker today. Dr. Okonoda made us to understand that mental disorders and substance use are common. And in fact, it is even the norm as against exception. Also made us to understand that there is a high level of reuptake to substance use, which of course is called a relapse, among persons with mental disorders or people with co-occurring disorders. And he also emphasized on why we should be concerned about co-occurring disorders or persons with co-occurring disorders. Of course, one of which I just mentioned, high level of relapse, and the fact that they are prone to frequent visits to hospital, exposed to violence, even HIV, among other diseases. And he also made us to understand that there are challenges associated with decision-making on the part of persons with co-occurring disorders, because in some cases, find difficult which one to even pay primary attention to. But in doing this, Dr. Okonoda made us to understand that addressing co-occurring disorders requires integrated treatment program. That he emphasized so much. And he also discussed the principles of recovery and the benefit of integrated treatment programs. And he made us to understand the differences between cure and recovery. And that, I must say, is a very important point to make, especially in the field of addiction science and even mental disorders or illness generally. So also talks about self-stigma, which we also know is very common among people with mental disorders, and talks about person-centered approach to treatment, and in fact highlighted the role of service providers and emphasized on partnership between the service providers and the patient, as against where the therapist feel as if he knows it all and want to dish out instructions to the patient. That is counterproductive. Thank you so much that you dwell so much on this and eventually give examples of programs, components reflecting person orientation. Thank you once again for that brilliant presentation. So let me check. Please bear with us. Ejikeme is still struggling to join. I think he's still having a network issue. So let me see here. Okay, we have a few questions now. Let me take this first. It says, is it possible to have facilities that can attend to both mental and physical health challenges at the same time? That question is coming from Jimmy Solomon. Thank you, Solomon, for asking that question. So, Dr. Okonoda, please go ahead to respond to that. If I may want to ask, I want to believe you got the question very clear.
Yes, so the question, Jimmy Solomon, thank you. That is my person. He says, is it possible to have both mental, facilities that cater for both mental and physical challenges? Yes, that is the integrated services we are talking about. And how does that happen? That's why people have been advocating for a general hospital setting. When I say general hospital setting, it doesn't mean general hospital in terms of a name, but in terms of having substance use disorder, mental health facilities, and even physical health facilities. For example, if you come to the place where I practice, that is Jos University Teaching Hospital, if people have physical health challenges, we just invite the specialist, or sometimes they just come and review. And sometimes when people have physical health challenges and then they have mental health challenges, they invite the psychiatrist to come and review. So when people also have co-occurring substance use and mental health challenges, they can also have hypertension and so on. Even in at the risk of looking at things and marketing myself, but in the facility network rehabilitation initiative that we offer, we have had people that we have brought specialists to come and review because they have had kidney problems, liver problems, and so on and so forth. So what we are saying is that people that have substance use disorders or mental illnesses should be offered the best of care, which is these integrated services, such that no area is left out. They are like you and I, they must have the best of care. So they must have access to the best of health care, either physical health care or mental health care or substance use disorder care.
Thank you so much, Doctor, for responding to that brilliantly again. Okay, I have another question here, but before then, okay, this is greetings from Stella Ngoke from Nigeria. She's saying, thank you, Dr. Konoda. That was brilliant. Thank you, Stella, for joining this session. Yeah, so we have another question from Nombulelo Meyowa. Please pardon me if I didn't pronounce your name very well. And the question is, how long should a person be in treatment for a mental disorder before they can start treatment for substance use? Giving example, I said, just a minute, doctor said, for example, here in my country, even though the country is not stated there, we recommend that they start mental health treatment before they are admitted at the rehabilitation center. Over to you, doctor.
All right, so the issue of how long, nobody really can put a particular timeline to it, because we know that the response of people to mental illnesses differ, even for physical illnesses. So there is nobody that can actually adequately predict how long somebody will respond. But the idea is that people are to respond to treatment of the mental illness in such a way that they can appreciate the cognitive and the behavioral and the processes that is involved in the substance use disorder treatment. Because if somebody cannot follow therapy, if somebody cannot follow counseling, because he's hearing voices that says that your therapist is even part of the problem, there's no way that person will be able to have the best of the rehabilitation process that you want to take him through. So there is no particular, I have admitted people before that I've told the family, based on the number of years this person have been going through this mental illness before they brought the person. And I told them, I said, from what I know and what it may take a while before this person responds. And incidentally, within 1 month, that woman responded very well. And there have been other cases in which one has thought, okay, this should not be so much of a problem, because the onset of the illness and the time they brought the person was not so long and everything. But in the process of treatment, you just see that things kept on evolving and so on and so forth. So we may not put a particular timeline to it, but the principle is that this person should be treated in such a way that you'll be able to follow therapy. Now, it doesn't mean that all the mental symptoms must disappear. It is that the person is adjudged to be able to follow therapy that is involved in substance use disorder.
Thank you so much, doctor. Greetings from Caroline, is saying saying thank you. Also, Magda Lilali saying great exposition, thanks. Okay, Caroline actually added that was a wonderful presentation. Then let's take this from Crispin Oguna. The integrated approach is awesome. I'm a recovery addict, 4 years clean. Do we have a detailed framework study to implement this elsewhere? I'm Chris from Kenya. So Crispin is writing from, is asking this question from Kenya. Thank you, Chris, for joining us. Over to you, doctor.
All right, so Christine, like I said before, experts have said, and in their practice and everything, and I dare to say so, that co-occurring disorders seems to be the norm rather than the exception most of the time. And even when, so in terms of when we talk about framework, some of the references I have here, if you go through them, you will see ways in which it has been practiced in other places and so on and so forth. But I also dare say that for most of us, especially those of us who are trained psychiatrists and psychologists and all that, many a times that is the framework in which we practice. Because most of the time, especially in our environment, people attribute the issue of substance use disorders and so on and so forth to many things. A weak morale and so on, and you are the one that's causing it by yourself. Why do I have to waste my money, my time to treat you? But when they start manifesting psychiatric symptoms and it becomes obvious, that's when they bring many of them. So that seems to be the norm rather than the exception. I hope I've been able to answer that question.
Yes, you did. And please, Chris, if you're not satisfied, even though we have very short, limited time, you can also try to reach out to us. We can link you up with a doctor for more explanation. So maybe we'll be able to take one or two questions, last questions briefly. This is from Joseph Simer. Jeremiah, and the question is, what possible specific intervention or interventions can you suggest if the client with co-occurring disorder or currently having a mental health problem is hesitant or ambivalent to attend the treatment under the aftercare program while they are undergoing social reintegration?
All right. Thank you very much. This your question brought to my mind a practice session that occurred when I was in recovery summit in Boston, and of course I missed it that time because I was not experienced. Something like this came up, and I said, well, we'll allow the person to go. When he reaches rock bottom, he will come. That's not the attitude. The attitude is, remember that we are talking about people being able to function in the roles that they have designed for themselves or the desire for themselves. So if somebody doesn't want to come because he has mental health problem, he has other issues and all that, this person must have something that is of interest. It may even be football. It may be that he wants to become an astronaut. Whatever it is not your place to say, oh, you can or you may not, or you cannot, you don't have the capacity. It is to use that area of interest to become engaging with the person. And in the process of your engagement with the person, once trust is established, you'll be able to now remember that ideally you should have skills in motivational interviewing and many other counseling skills. So in the process of engaging this person, that's how you start chipping in your motivational interviewing skill and everything, and the person will come to the understanding that, oh, I need this. So we must be people who are open-minded and vast. You must be like a coach. You must be like a manager who is interested in the person. And so you use it to draw them in. I know that there was a time I had to get somebody that was good in script writing and music, because I had a lot of young people, they want to do music, and their parents say, no, you cannot do music. But that's what they wanted to do. So we use that to engage them. And of course, in the process, some have been able to go back to law school, who have left university, and they are now lawyers. They didn't want to hear about law before, but because we engaged them in the things that they loved, and then of course we now want their confidence, we're able to get into that area and they are doing well. So that's what we do. Remember, we talk about partnership. In fact, I have an acronym that says you have to keep pace with the client or with the patient. What does that mean? P means partnership. So it's in the spirit of partnership. A means acceptance. Remember that acceptance does not mean that you approve of it, but you accept the person as an individual. So you'll be able to relate with the person better. C is compassion. So it's in the spirit of compassion. You move from empathy, putting yourself in the person's shoes, to compassion, helping them to solve their problem. And then E is evocation. So you'll be able to help this person to bring out the best, the strength that they have, that they don't know they have. So when you keep pace with clients, you get the best out of them, even when they seem apparently unwilling at the beginning.
Thank you so much, Doctor. We are almost running out of time, but quickly, of course, this is greetings from Meyowa from South Africa. Another greeting from Judith Azuma, more of brilliant presentation, nice presentation. Of course, Emmanuel Akma from Nigeria. Then this possibly will be the last question we'll take. If we can do that within 1 minute, as if that is response from you now. It's from Nicholas Okwat. And Nicholas is asking, kindly expand on why in some cases relapse are common. Is it because the models used are not sufficient? I actually want to believe that Dr. Konoda has responded so much on this, except you still want to say something on that. Otherwise, greetings again from Adesanya, from BUTH, and so on. So I think that is the more question we can take. Please respond to that. Time is not always our friend.
All right. There are many factors. Relapse will be high if, for example, people are not trained enough to be able to appreciate or to diagnose a co-occurring disorder in the person. Somebody comes and is using substances, you are not able to pick that this person has depression. Even in physical illnesses like stroke and all that, if you are not able to pick that some people have depression and you are not treating it, you are not going to get the best out of them. Not to now talk of with substance use disorder. So the expertise, that's why we talk about the expertise of the service provider. And even if you are not trained to be able to treat physical illnesses or mental illnesses, you should be able to pick it and then make a referral or invite the specialist that will help. And that will help. And then, of course, we all know that the skill of the individual, of the therapist, but we cannot also take away the part of the client. We talk about recovery capital. So if people have good recovery capital, they can recover well. If they have poor recovery capital, recovery may be more challenging. And that's why we step in, or we never lose hope on anybody. We step in to use our expertise to help people. It may be longer, may be more challenging, but everybody has hope.
Thank you so much, Doctor. And again, thank you, Isaiah Ogenero and Chinyere Ezegigala for joining us and for at least adding to words of encouragement to our speaker for today. So once again, like I said, time is not always our friend on this program, and this is the much we can take. We appreciate each and every one for being part of this session. And we encourage you to join us again in May for another edition of ISSUP Nigerian chapter bi-monthly webinar. Of course, we cannot over appreciate our speaker for today. It looks like I didn't give you opportunity to say one last minute. Do you still have one last minute to say before I end the session, Doctor?
The last thing I want to say is that substance use disorders and mental illnesses are life issues, and everybody should be treated in such a way that we give them the best. So let's treat people with hope. Let's be merchant of hope and not despots. Thank you very much, and God bless you.
Wow, what a way to end this session. I think that has summarized everything. So once again, I say thank you for being part of this session. And we also appreciate ISSUP, who has always provided us the technical support to be able to at least reach out to you as part of our bi-monthly and knowledge update series. So see you again in May by His grace. Thank you and bye for now.
Thank you. Thank you. God bless you.
Yeah.